from Association of Surgeons of Rural India, from the EC of ASRI, from the desk of Dr. Natkarni, the President, Raj Sekhar, Vice President, Dr. Jnana Guruswamy, Honorary Treasurer, and me being the Honorary Secretary. I welcome you all to this first series of lectures, actually. And so uh, today we are going to have a very interesting discussion on safe thyroid surgery. It's like some people have joined through Zoom, and the other people are joining by YouTube link actually, and it will be put in our YouTube as well as the Facebook platform also. So actually, I thank Dr. Fareen Khan, who's alumni from SGPJ, and she has got a great experience in thyroid surgery. She will be moderating this panel discussion on safe thyroid surgery, and she'll be talking also on anatomy of thyroid for surgeons. And next, we will have four young faculty assistant professors, Dr. Spandana Jagannath. She will be speaking on sutureless thyroidectomy and adjuncts for sutureless thyroidectomy. And Dr. Divya Priyadarshini Bera, and she will talk on parathyroid, the importance of parathyroid preservation, how you preserve parathyroids during thyroid surgery. RLN anatomy and preservation will be by Dr. Rinal Mascarenhas, and the newer kid in the block, robotic thyroidectomy, Dr. Madhu Kumari will speak. And we have a surgical expert who has been a part of 9,000 thyroidectomies, Dr. PRK Bhargav, who will be joining us also. So without wasting much time, I will request Dr. Fareen to start her talk. Am I audible? Fareen, can you start?
Yes, I'm just sharing my.
Yeah, sure. Okay.
So, is my screen visible now?
Yes, Fareen, it's clearly visible.
So, good evening, one and all, and to all my MCH fresh pass out assistant professors. Hello to all of you from Delhi. Sir, thank you so much for this opportunity. So, I'll be starting immediately. So here, starting with briefly about surgical anatomy of thyroid, taking into consideration like that a lot of general surgeons might be on this today. So yeah, so from thyroid surgery has the journey of thyroid has come a long way from horrid butchery to supreme triumph, and it has been a lot in the history from the past. So the term thyroid was derived from the Greek description of a shield-shaped gland in the anterior neck, thyroides. There were in the past ancient times, numerous medical and attempted surgical therapies have been tried for thyroid diseases like seaweed, sponges, cauterization, setons, drainage, even shoestring ligation. Till 19th century Europe, when thyroid resection was attempted by several European surgeons with typically disastrous results. So, according to Thomas Akins in the Gross Clinic in 1875, no sensible man would attempt to extirpate a goitrous thyroid gland. So, he, in his during his clinics, said that nobody would uh, be able to finish this horrid butchery. So overall mortality then was more than 40%, and it was officially banned by the French Academy of Medicine in 1850 on performing thyroidectomies because no patient would survive. Even Bilrod, the legendary surgeon who had many of his firsts, was not so fortunate with his thyroid surgeries. He had complications with more than 25% with recurrent laryngeal nerve, and patients ended up in tracheostomy, and there was huge risk of mortality. In the late 19th century, however, we had Cocker, who later received a Nobel Prize in 1909. He was a very, very meticulous surgeon with an initial mortality rate of 14.8%, which came down to 0.18%. He had a wonderful RLN injury rate of less than 1%, which, if followed, the principles still hold today to preserve the nerves, preserve the parathyroid glands, limit the bleeding, and replace thyroid hormones. So Halstead was both their students, as in the Cockers and Bilrods, and in his belief, it was the extirpation of thyroid gland typifies perhaps better than any other operation the supreme triumph of the surgeon's art. So speaking of which, thyroid development and thyroid anatomy is one of the most important for a surgeon to perform a safe thyroid surgery. So quickly into embryology of the thyroid. So thyroid develops from primitive pharynx, arises as a midline diverticulum from the foramen cecum, which is floor of the mouth, to the goes up to the floor of the pharynx. So it develops as a thyroid primordium, which is an endodermal pouch. Also, there is neural crest component to it from the ultimobranchial bodies, from which the C cell arises. So the main portion descends into the neck and develops into a bilobed solid organ. And in this picture, this is the tract of descent of the thyroid gland. And by 6 weeks of age, the thyroglossal duct, which is seen, is usually reabsorbed, and the hyoid cartilage usually chondrifies. So the distal aspect of the path of descent is retained as a pyramidal lobe. There is a right lobe and a left lobe connected by isthmus. That is the medial enlarge and a lateral enlarge, which we read in our textbooks. The medial enlarges form the isthmus and parts of the lobe, and lateral enlarges forms the tubercle of Zucker candle and the lateral aspect of the thyroid lobes. So in a picture, this is summarized from foramen of cecum, which is the site of origin of the thyroglossal duct, endodermal growth down to it, and then it goes down and can actually migrate to ectopic locations, and that's why we need to have a keen knowledge about the embryology and descent of the thyroid. The later applied aspects of it will be dealt with during the rest of the presentation. And the calcitonin producing C cells arise from the fourth pharyngeal pouch, which migrate down, and they are of the neural crest origin. So the normal thyroid gland weighs about 20 to 25 grams. The functioning unit is the lobule supplied by a single arteriole, and each lobule consists of follicles lined by cuboidal epithelium. And the follicle contains colloid in which thyroglobulin is stored. Won't be talking much about the physiology. So here, this is a very good table which is present, which is there in Randolph, and it talks about embryologic anomalies associated with the medial and lateral thyroid enlarges. So, the median. Please, can you mute whoever is speaking here? One second. Okay, so there are anomalies in the medial enlarge, which is agenesis, the isthmus pyramidal lobe. The isthmus may be present, may be absent. The pyramidal lobe may be grossly
Karin,
enlarged.
just hold on. I'll ask them to. One plus, who is one plus not? I think again he was made the host. Actually, removed me as a host. I will ask him.
Sure.
हेलो, मेरे को होस्ट बना दो, नहीं म्यूट कर दें, सब बहुत बात कर रहे हैं, वी आर नॉट एबल ठीक है. Sorry for the interruption. You can carry on.
Yeah, so anomalies of descent along the thyroid line would be present of a lingual thyroid, a sublingual, or a prelaryngeal. Then other accessory ectopic locations can also be present, but they are rare, but not to be forgotten during surgery. Lateral enlarge would be non-fusion with median enlarge. Agenesis, like complete absence of the thyroid, and pharyngeal pouch remnants like a thymic rest high up and level 2, or any remnant of ultimobranchial body. And we have a term called lateral aberrant thyroid, which is presence of thyroid tissue within the lymph nodes. Then there can be certain anomalies with the supply of arteries and the nerves, which eventually will be dealt with during the course of the presentation. So the thyroid lobe lies anterior to the trachea, and most part of it, the posterior part of it, which is the tubercle, lies actually in the tracheoesophageal groove. It is anteromedial to the carotid sheath. This anatomy is most important during the dissection. On medialization of thyroid, common carotid is the first structure which you should encounter before, just before you ligate the middle thyroid vein. Posteromedial, it lies posteromedial to the anterior staph muscles, which are the sternocleidomastoid, sternohyoid, and sternothyroid muscles. So the supply of thyroid, it has a very rich vascular supply. It has superior thyroid artery is a direct branch from common carotid artery. It's the first branch which supplies the superior pole and anastomosis with the opposite branch, forming a rich vascular network. Inferior thyroid artery, though named inferior, may not enter from the inferior pole of the thyroid. It usually enters from somewhere middle, upper thirds and lower two-thirds of the thyroid, and is direct branch from thyrocervical trunk, which comes from the subclavian artery. Sometimes there is a thyroidema artery which arises directly from the arch of aorta and can lead to torrential bleed if missed during dissection, or not, or if ligation is not carried out properly. The same named veins, there are three veins which drain the thyroid superior pole. Middle thyroid vein is short stout vein which directly drains the middle part of the thyroid and drains directly into the IJV. So this vein you would encounter first in your initial steps of thyroidectomy when the thyroid is mobilized medially. Inferior thyroid veins directly come from the brachiocephalic and form a rich network including the inferior pole of the thyroid. Lymphatic drainage, predominantly from the central compartment lymph nodes. The lower pole, middle pole structures directly drain into the level 6 compartment and down into the anterior mediastinum. All other structures, the rest of the gland, that is the superior aspect and the posterior aspect, drain into the lateral compartment lymph nodes. The Delphian node comes from the curse of Delphian, comes from a Greek mythology, uh, which means it highlights any possible pathology in thyroid, and hence it's called the Delphian node. May not always be involved. It usually gets involved in thyroiditis, and so the applied aspect here is sometimes just in medullary carcinoma thyroid, which happens to occur and present in the posterior and the superior aspect of the thyroid. Usually the drainage happens to the lateral compartment instead of central compartment. So if based on your calcitonin levels, lateral compartment lymph node should be dissected very carefully. So innervation of thyroid gland is by the cervical sympathetic chain, by the superior, middle, and inferior cervical ganglion. It has no secretomotor parasympathetic innervation. As we all know, thyroid is an endocrine gland and is regulated by hormones. The superior laryngeal nerve and the recurrent laryngeal nerve are closely related to the gland in their course and is important during thyroid surgery, but it has no role in innervation of the gland. So this is axial cut section of the neck, which shows a normal anatomy of the thyroid gland, immediately behind which is trachea with pretracheal fascia engulfing the entire lobe of the thyroid with its deep condensations behind, called as the Berry's ligament, posterior to which is the thyroid gland, the esophagus. Laterally are the common carotid and the IJVs on both sides. Anteriorly, it is protected by a cover of strap muscles, a thin layer of platysma and fat. Posteriorly is the prevertebral fascia, involvement of which at one point was considered as inoperable disease. However, not so now with the latest developments. So ligament of Berry is deep condensation of the pretracheal fascia, which attaches to the cricothyroid, which attaches the gland to the laryngeal apparatus to the cricothyroid cartilage. The relationship is very important because the RLN courses very near to the this ligament of Berry and pierces into the cricothyroid membrane to provide motor supply to the vocal cords. So as you can see here, this is the tracheoesophageal lobe. This is from looking from posterior aspect, from behind the neck. This is the thyroid gland. Here is the inferior thyroid artery. The relationship of RLN is inferior and posterior, medial and posterior to the inferior thyroid artery, and it goes close to, very, very close to the Berry's ligament and pierces the cricothyroid membrane. So other important thing in thyroid is something which has been uh, encouraged by everyone, the most of senior surgeons. It was brought in by Delbridge, the concept of capsular dissection. So the thyroid has a false capsule, which is the condensation of pretracheal fascia, and then there is a true capsule of the thyroid, below which is the fine, delicate venous plexus closely adhered to the gland substance. So the ideal plane of dissection should be between the false and the true capsule. This is where the subcapsular dissection comes into play. So this field is usually avascular. So once you enter or disrupt the true capsule, sometimes it may be inevitable, but if it torrentially bleeds, then the best thing to do is apply pressure and continue your dissection, because there is no way you can you can stop this bleeding. It will bleed more. The more you cauterize it, the more it will bleed. So this is a tip. If during your capsular dissection something bleeds, give pressure, wait, and continue your dissection. This is just in comparison with the prostate, where the vascular plexus is between the false and the true capsule. So superior laryngeal nerve arises from the vagus and just below the nodose ganglia, and it gives off an internal branch which is a pure sensory nerve, and gives off an external branch which has a motor supply to it. And this is in very close relationship to the superior thyroid artery. So, uh, this is Cernia's classification based on where the superior laryngeal, the external branch of superior laryngeal nerve, crosses near the superior pole of the thyroid and enters into uh, the cricopharyngeus. So, type 1 is where the nerve crosses more than 1 centimeter above the superior pole of the thyroid. Type 2A and 2B are where the nerve is just at the pole, and type 2B is where the nerve crosses 1 centimeter below the pole. So type 2B nerve is the most at risk nerve uh, during the superior pole dissection. So Cernia had published this in the year 1992, and subsequently the concept of medial space of reefs came from Australia, where this medial space is a generally a avascular space between the medial surface of thyroid and cricopharyngeus muscle, where the nerve, where the superior external branch of superior laryngeal nerve traverses. So here, the tip would be to hold the thyroid lobe laterally with an instrument like artery and carefully dissect with a relatively blunt instrument. People use a right angle, Leahy's right angle, or mosquito, to carefully see where your nerve is crossing the pedicle, and then ligate the pedicle near the pole of the thyroid. Before this, superior parathyroid should be identified during thyroidectomy. This nerve is important because it may add to aspiration and lower the pitch of voice post surgery. It may not be as relevant as recurrent laryngeal nerve injury, may not come out as obvious, but definitely some component of aspiration does exist if external branch of superior laryngeal nerve is injured. So this anatomy is for RLN, that is dissection where the lobe is completely medialized, and the RLN is present in the tracheoesophageal groove inferior or deep to the inferior thyroid artery. So here the tip is to not ligate the trunk of the inferior thyroid artery, but individually ligate the branches close to the gland. I'm not going into the relationship of crossing of RLN with inferior thyroid artery, that I think Dr. Rinel will deal with in detail. All I want to say is RLN, especially on the right side, has an oblique path, and on the left side has a longer recurrent route and goes very close to the tracheoesophageal groove. On the right side, you may encounter a non-recurrent nerve, that is in this picture, where the nerve directly enters into the cricothyroid muscle, and this happens in less than 2% of the cases. And most of the time, RLN passes deep to the inferior thyroid artery trunk. Very less cases, like it's approximately in the tune of 70 to 80% of the times, RLN would pass deep to the inferior thyroid artery. Whereas in less number of cases, it would pass through over, as in anterior to the inferior thyroid artery, or pass between the branches of the inferior thyroid artery into the gland. So this dissection is very important to keep the nerve in view while doing it, or try to be as close to the gland while dissection. So this is about the thyrothymic descent coming from the foramen cecum to going up to the mediastinum. So the thyroid rest can be present anywhere in this path of descent. However, thyrothymic remnants as such are classified when they are present below the lower pole of the thyroid. These are ectopic locations, most common being lingual, followed by mediastinal remnants. So again, the same picture, thyrothymic remnant would be a pyramidal lobe, would be a thyrothymic ligament along the path of descent, could be an isolated one or a lingual. So Sackett et al. Presented this classification of thyrothymic remnant is very important during dissection and complete resection of thyroid gland, because any thyrothymic remnant left behind will have an active functioning thyroid. So it can be either functional, or it can prevent patient from becoming hypothyroid, especially in cases of papillary thyroid cancer. So type 1 is where there is just a protrusion from the lower pole of the gland. Type 2 is it is a more than type 1 protrusion, but still attached by a thick gland remnant. Type 3 is similar to type 2, but the attachment is fibrous. And type 4 is an isolated mediastinal remnant. And blood supply of this kind of remnant is usually from the mediastinum. So this was the paper which was presented at the Royal Australasian College of Thyrothymic Rest, Incidence and Relationship to the Thyroid Gland. This classification here is Pellizo's classification of tubercle of Zuckerkandl. Tubercle of Zuckerkandl is predominantly C cell rich protrusion of the lateral enlarge of the thyroid lobe, mostly posteromedial and into the tracheoesophageal groove. Grade 1 when it is less than 0.5 centimeter, grade 2 when it's between 0.5 centimeter to 1 centimeter, and grade 3 when it is more than 1 centimeter. This is actually a pointer towards RLN. RLN is usually closely related to it medially and posterior to the tubercle of Zuckerkandl. More than 70% of the nerves will follow this path of ascent in the tracheoesophageal groove. However, you should be wary that tracheoesophageal groove growth of tubercle of Zuckerkandl may be so enlarged that the nerve can either be lateral or be passing anterior to it, especially when the gland enlarges and enters into the tracheoesophageal groove behind. So this was a paper by Pellizo and its classification on the tubercle of Zuckerkandl. So despite all technologic advancement, the same principle will always apply for a thyroid surgeon. To understand the relevant anatomy, including embryology and pathophysiology of the thyroid diseases, to be precise and meticulous in your dissection, ask for help when needed, and avoid injury to surrounding structures. Because no matter what you do, at the end of it, a good thyroid surgery is equal to low rates of calcium requirement of the patient and intact voice and aspiration and no aspiration. So thank you.
Thank you, Farin. Very interesting talk, actually. Like you covered almost all aspects what a thyroid surgeon needs to know, actually, and very, very important to emphasize on no requirement of calcium, normal voice, and no aspiration. That's what we all aim to do, actually, by whatever route we have to remove this thyroid, actually. And mm, I think should we ask all panelists to speak and then take questions at the end so that
Absolutely, sir. I think so. Yes.
ठीक है. फिर like we invite the next speaker,
Yes.
Dr. Spandana Jagannath, who's an assistant professor at SGPGIMS, to share her screen and start her presentation. Over to you, Dr. Spandana.
Welcome, Spanna.
Good evening, everyone. Am I audible?
Yes, you are.
You are audible, please.
Good evening, everyone. Thank you so much for the organizers for giving me an opportunity to talk about sutureless thyroidectomy and adjuncts in this panel discussion. Let me just share my slides. Is it visible to all?
Yes, it's visible.
The topic that I'll be briefly describing for some time would be sutureless thyroidectomy and adjuncts. The overview of my presentation would include a brief introduction to the topic, rationale for using sutureless thyroidectomy, its basic principles, what are the evidence and surgical outcomes, the adjuncts used, and I'll be summarizing my presentation. Thyroidectomy is the cornerstone procedure in endocrine surgery, performed globally for both benign and malignant thyroid disorders. Historically, thyroid surgery has relied heavily on meticulous suture ligation of blood vessels due to the gland's rich vascularity. It receives about 1 to 2% of the total cardiac output. An exhaustive hemostasis makes it possible to prevent potential lesions of the parathyroid glands with consequential hypoparathyroidism, damage of the laryngeal nerves, and dangerous postoperative bleeding. Thyroid surgery has undergone a remarkable transformation over the centuries, evolving from a once highly risky, often fatal endeavor into a safe, standardized procedure. By the 18th century, the outcomes of thyroidectomies were dismal. The excessive bleeding from the superior thyroid artery or the internal jugular vein often led to death. There was little understanding of the vascular anatomy of the neck. In the late 19th century, Theodore Cocker emphasized the importance of stepwise vascular control and advocated ligating vessels close to the gland, a principle that remains fundamental even today. Mid-20th century saw the introduction of double ligation technique where arteries were ligated with two silk sutures to avoid slippage, vein ligation before mobilization, especially the middle thyroid vein, and use of clamps and hemostats with ligature placement under direct vision rather than blind clamping. In the 21st century, the focus has now shifted to minimizing surgical trauma and improving cosmetic outcomes. Energy devices such as harmonic scalpel, ligashore, and advanced bipolar sealing systems have replaced traditional ligatures. During thyroid surgery, adequate hemostasis and keeping the operative field dry and clean is of utmost importance. Sutures and ties constitute one of the simplest and the longest established hemostatic options, where conventional clamp and tie thyroidectomy consists of devascularization of the thyroid by double ligation and dividing the branches of the thyroid vessels. However, over the last few decades, the emergence of electrosurgery, referring to the use of high-frequency electrical current to coagulate and cut tissues, has revolutionized thyroidectomy, leading to the concept of sutureless thyroidectomy. It is defined as thyroid dissection procedure where hemostasis and tissue dissection are accomplished without the use of conventional suture ligation, relying instead on energy-based techniques. Sorry. Some of the drawbacks that have been seen by surgeons by usage of conventional clamp and tie techniques are the longer operating time. Tying secure knots is time consuming, especially deep in the neck where visibility is limited. In high volume or resource constrained centers, this prolongs the anesthesia time, increases turnover delays, and raises overall costs indirectly. Even with meticulous techniques, small vessels can be missed, they can slip from the clamp, or a ligature might cut through the fragile vessel wall. Even if one ligature slips post-operatively, it can cause life-threatening neck hematoma, risking airway compromise. Clamp and tie technique requires more dissection and retraction to visualize each vessel for safe ligation. This increases the manipulation of surrounding tissues like the recurrent laryngeal nerve and the parathyroid glands. Knot tying is technically demanding, especially in a small confined field. Fatigue or inexperience of the surgeon may lead to insecure knots, improper placement, or loose ligatures. Clamp and tie technique is also technically challenging through small incisions or trocars. Knots are harder to tie in limited access fields, making traditional methods impractical for endoscopic or remote access thyroidectomy. silk or other suture materials left behind can also act as a nidus for infection, cause stitch granulomas, or chronic sinus formation. Some of the energy-based sealing devices in routine use are electrocautery, both monopolar electrocautery and bipolar electrocautery. Advanced bipolar sealing device like ligashore system, ultrasonic scalpel like the harmonic scalpel, and the hybrid system that is a thunderbeat sealing device. Energy is converted from electromagnetic to kinetic and finally to thermal energy in order to create one of the number of effects on cells and tissues as is shown in this figure. Hemostasis by energy-based devices is governed by three fundamental factors: the tissue compression that is applied, the heat that is produced, and the duration of the contact. One is to know what is the burst pressure of the artery to understand the working of an energy-based device. In simpler words, a higher burst pressure means a more secure seal. It refers to the maximum internal pressure that a sealed vessel or a tissue pedicle can withstand before the seal fails and leaks. For energy-based sealing devices, burst pressure is a measure of the strength and reliability of the thermal or the electrosonic seal. A high burst pressure means a more secure seal, and a good vessel seal should have a burst pressure of at least 2 to 3 times higher than the vessel's normal systolic blood pressure. Studies have shown that perpendicular blood vessel seals are stronger than those made at an angle. The burst pressure is significantly higher when applied perpendicular than at an angle to the smaller functional diameter. This suggests that surgeons should aim for a perpendicular approach when sealing blood vessels to ensure optimal strength and to prevent leaks. Coming to electrocautery in a brief, modern electrosurgery systems pass a high voltage, high frequency current through the patient. Cutting is produced at high current but at lower voltage setting, whereas coagulation is produced at relatively lower current and high voltage setting. The cutting mode employs a continuous sinusoidal waveform, whereas coagulation settings use an interrupted mode. Electrocautery, both bipolar and monopolar, produce significant heat in the tissue at a relatively lesser time of contact with minimal compression of the tissue. Coming to the harmonic ultrasonic scalpel, the principle that is used is the ultrasonic technology. The piezoelectric ceramics in the transducer of this energy device cause ultrasonic contraction and expansion of the active titanium blade, which causes energy sealing via friction between the jaws and the tissues. Proteins are denatured by friction at 55,000 Hz, breaking the hydrogen bonds and forming a sticky coagulum without transfer of an electric current. The vessel is divided and simultaneously the coagulum produces sealing. It can seal vessels up to 5 mm in diameter, and the temperature that it can reach is up to 50 to 100 degrees centigrade. A meta-analysis in 2024 demonstrated that the use of harmonic scalpel significantly reduced the risk of postoperative neck hematoma, the length of hospital stay, and the operative time when compared to conventional clamp and tight thyroidectomy. However, no statistical advantage of harmonic scalpel was seen over conventional technique with respect to postoperative hypocalcemia and recurrent laryngeal and the EVSLN palsy. Coming to the ligashore bipolar vessel sealing device, it works on the principle of a computer-controlled bipolar diathermy. It is a combination of both mechanical pressure and a high current, low voltage radio frequency bipolar energy. It represents a new generation of instruments that use integrated active feedback control to optimize power output. During activation, the response generator's computer senses the density of the grasped tissue and it automatically adjusts the precise amount of energy that is to be delivered. When the sealing is complete, as the impedance reaches a critical level, the microprocessor control feedback will automatically terminate the pulse and it is indicated by a clear audible tone. It can seal up to vessels of 7 mm in diameters and it can reach temperatures up to 50 to 80 degrees centigrade. A systematic review in 2021 showed that ligashore vessel sealing device provided better result in terms of intraoperative and postoperative blood loss, postoperative drain volume, incidence of transient or permanent palsy of the recurrent and the external branch of superior laryngeal nerve, postoperative, transient or permanent hypocalcemia, and length of stay when compared to conventional clamp and tie technique. Coming to Thunderbeat vessel sealing device, it works on the principle of both ultrasonic energy and bipolar energy. It integrates the ultrasonic energy for dissection with advanced bipolar energy that coagulates the tissue by denaturing the collagen and the elastin to form a seal. The upper jaw is a bipolar jaw, and the lower jaw is an ultrasonic and a bipolar probe, which facilitates these two functional modes. There are two modes that can be activated. One can seal and cut, while the other is only a seal mode where only coagulation is done. It can also seal vessels up to 7 mm in diameter. Coming to all these energy-based devices at a glance, as discussed, harmonic and harmonic can ligate vessels up to 5 mm in diameter, whereas ligashore and thunderbeat can seal vessels up to 7 millimeters. The burst pressure is significantly higher in thunderbeat, while it is lowest for harmonic. The lateral thermal spread is about 2 to 3 millimeters in both harmonic and thunderbeat, while it is less than 1% in ligashore. The lateral thermal spread is an important safety concern in cases of thyroidectomy. The temperature generated at the tip of the instrument varies considerably with the type of instrument used, the power setting, and the length of the time of application of these probes, placing structures like recurrent laryngeal nerve, the parathyroid glands, trachea, and the esophagus at risk. At the highest power setting, with increasing duration of application, the temperature that is recorded at the tip of monopolar and harmonic significantly increase, whereas there is little difference seen with bipolar and ligashore. Also, when comparing temperatures adjacent to the tips of the instrument and also more than 1 centimeter away from the tip of the instrument, only the use of monopolar diathermy results in temperature rise to more than 42 degrees in the tissue, while it is not seen in case of bipolar, harmonic, or ligashore. The time taken for the raised temperature at the tip of the instrument to return to a safe working temperature, which is lower than 42 degrees centigrade, is shown in this table. Surgeons can minimize lateral thermal injury by choosing the lowest effective energy level for each tissue. Continuous prolonged activation causes more heat buildup, so usage of short bursts instead would allow the tissue to cool. Critical structures are protected by maintaining a buffer zone, and it needs to be made sure that the tip is not pressed directly against the nerves of the parathyroid. Good exposure also reduces the need for prolonged activation near the critical structures. Saline irrigation or wet gauze can absorb excess heat and minimize lateral thermal energy. Surgeons need to possess a working knowledge of functioning of each of the energy device and the surgical knowledge to minimize thermal injury. One another issue of concern is the surgical smoke which is emanated by these energy-based devices. They composed 95% of water vapor which acts as the carrier. It can also contain bioaerosols, dead and live cellular material, and viable viruses and bacteria. Toxins such as carbon monoxide, acrylonitrile, small amounts of hydrogen cyanide, benzene, and formaldehyde can be present in varying proportions. Inhaled particles are usually as small as 0.07 microns, and they can be easily deposited in the alveoli, and chronic exposure can cause respiratory problems. Coming to the surgical technique of sutureless thyroidectomy in brief, as is done in conventional thyroidectomy, it needs exposure, a good exposure of the thyroid gland with the subsequent ligation of the middle thyroid vein. The superior pole of the thyroid gland is dissected free of the overlying strap muscle, and then it is retracted introlaterally to facilitate entry into the relatively avascular cricothyroid space. Then vessel seal is performed by 3 separate but parallel seals on the superior pedicle prior to dividing it flows to the superior pole of thyroid. Dissection of the superior pole should not continue below the level of inferior border of the cricoid cartilage, as this will put the superior parathyroid and the recurrent laryngeal nerve at risk. Next is the dissection of the inferior pole, where the overlying strap muscles are dissected of this inferior pole and the superficial inferior thyroid veins near the midline are divided. The inferior parathyroid is identified when possible in the vicinity and it is released from the thyroid gland. Then the capsular dissection and identification of recurrent laryngeal nerve is done. Division of the ligament of Berry is done to free the thyroid of the trachea. A randomized control trial was done in 2019, which showed that the operative time for thyroidectomy was significantly different in the three energy devices that are used, being the Thunderbeat, Harmonic, and Ligosure. For thyroidectomy, the Thunderbeat also showed the least operative time, followed by Harmonic and Ligosure devices. Intraoperative bleeding, the drainage output, post-operative serum parathyroid hormone level, post-operative hospital stay were not significantly different among three energy devices. A systematic review in 2022 showed that thyroidectomy using a sealing device is safe and a successful alternative to the clamp and tie thyroidectomy. They also showed that they also concluded that energy-based devices are better due to reduction in operative time, perioperative hemorrhage, post-operative drain volume, temporary and permanent hypocalcemia, temporary and permanent RLN palsy, and post-operative hospital stay. A systematic review in 2020 also showed that all these three energy-based devices, they represent a safe, effective alternate to the traditional clamp and tie technique. Operative times were again significantly seen to be decreased with employment of these energy-based devices. The RLN injury rates were statistically comparable between the three energy devices. And they concluded that experience and skills of the surgeon play a decisive role more than the specific energy-based devices that are employed. Coming to the adjuncts that are frequently used to facilitate a sutureless thyroidectomy, we have magnifying loops, which help in enhanced precision in dissection. We have hemostatic agents, which help in the diffuse ooze that may be present during dissection. Vascular clips and loops for a selective control of large vessel, which may not be tackled by the energy-based devices. IONM, ICG for RLN and parathyroid preservation, suction dissectors, and smoke evacuators. I will only be discussing in brief about the hemostatic agents and the vessel clips. IONM and ICG will be discussed by the other panelists. Coming to the hemostatic agents, the hemostatic patches that are usually used are of two types. The biologically active type has a sealant matrix which contain human coagulation factor as a coating on the surface. When it comes in contact with the body fluids such as the blood, these components active and they initiate the last phase of the human coagulation cascade. And it leads to the formation of a fibrin clot. They're mechanically stable that provide adequate sealing. Examples of these are the surgery flow that are in use. Physical agents are the second group, which enhance hemostasis using a passive substrate like that of an oxidized cellulose patch, which when saturated with blood will provide a surface for platelet adhesion and aggregation, thus initiating the formation of a durable clot that doesn't wash away or bleed again when irrigated. A meta-analysis in 2018 showed that hemostatic agents did not significantly decrease the incidence of complications such as hematoma, seroma, infection, recurrent laryngeal nerve injury, or hypoparathyroidism. However, they did significantly decrease the operative time, drain output, and hospital stay when compared with conventional agents. Talking briefly about the vascular clips, they can be either plastic or titanium clips, and they are to be selectively used when there are large caliber vessels or when lateral thermal injury is a concern. The mean arterial bursting pressure of these clips remain superior to the energy sealing devices. They have no risk of lateral thermal injury, but they do have a risk of clip dislodgement and adhesions. Summarizing my presentation, sutureless thyroidectomy is an integral part of modern thyroid surgery now. However, the goals remain constant. It is to secure an adequate hemostasis, preserve the nerve and the parathyroids, and minimize complication. Sutureless thyroidectomy is safe, efficient, and reproducible. However, careful case selection, a sound anatomical knowledge, and respect for surrounding vital structure remain paramount to achieving optimal outcomes. Some of the points that I would like everybody to remember is that the use of these energy-based devices have a learning curve. One needs to be prepared with the device malfunction and must always have traditional backup options. Anatomical knowledge remains crucial, and a lack of basic understanding of these energy devices is a major obstacle to using them effectively and safely in the operating room. Energy-based devices have transformed thyroid surgery by enabling sutureless techniques that are faster and efficient. However, the same tools that make our work easier demand greater responsibility and understanding. As we embrace technology, it is paramount that we stay guided by skill, judgment, and patient safety. Thank you.
Thank you, Dr. Spandana. Actually, very important aspect of thyroidectomy now. A lot of adjuncts and sutureless thyroidectomy is a very important thing. She covered every aspect of it in detail. Thank you so much. And now we again invite the next speaker, Dr. Divya, to share her presentation on parathyroid preservation. Dr. Divya is an assistant professor at SGPGIMS, Lucknow. She will talk on parathyroid preservation. Is Divya there?
Good evening, sir.
Good evening, Divya.
So I'll be presenting for Spandana's laptop.
Yeah, sure.
First of all, good evening, everyone. Thank you so much for giving me this opportunity. Shall I share my slides now?
Yeah, sure.
So I'll be talking about parathyroid preservations in terms of in related to safe thyroidectomy.
Your slide is not visible.
Is this visible now?
No, Divya, it's
No.
not visible. Can you open in the same window? Yeah. Yes,
Is
it's
this
visible
visible
now.
now?
Yes. Go to presentation. Yeah.
Yes. So I'll be starting with the concept that why parathyroid preservation is important and why does this matter, followed by the strategies to preserve parathyroid during thyroidectomy. Others adjuncts use during surgery to preserve parathyroid, followed by a complete embryological and anatomical knowledge about the parathyroids and studies related to it. So, why preservation of parathyroid gland matters in thyroidectomy? As we all know, that if you fail to preserve a normal gland, that leads to hypoparathyroidism, both temporary and permanent, as being evident in different studies. The temporary hypoparathyroidism following a thyroidectomy ranges from 30 to 60% in various series, and the incidence of permanent hypoparathyroidism after thyroidectomy is from 0 to 3%. However, it is often underreported. As a result of hypoparathyroidism, it can cause increased hospital stay following increased cost, increased morbidity, use of lifelong medications in case of permanent hypoparathyroidism, and decreased quality of life. Along with that, also it can permanent hypoparathyroidism can result in renal insufficiency, seizures, and calcification, and other things. This failure to preserve preserve the normal gland can be challenging for by virtue of a normal anatomy and location of the parathyroid gland, which can be because of variable locations, size, and color of the parathyroid glands, which can mimic with various other tissues surrounding the parathyroid gland, and a precarious blood supply to the parathyroid gland, which is often supplied by end arteries, resulting in injury of any of the arteries can prone any of the parathyroid gland for devascularization, hence hampering its function following the thyroidectomy surgery. So coming to strategies, various strategies for preservation of parathyroid gland during thyroid surgery. It starts with identification of the parathyroid gland, following preventing injury to the parathyroid gland and its vasculature during surgery. And if there's inadvertent injury of the parathyroid gland, following this, we can do an autotransplantation. Starting with intraoperative identifications, it can be a visual inspection by naked eye identifications, or identification of the viability of the parathyroid gland by doing a capsular incision, and confirmation of the parathyroid gland by doing a sync test. So these are the on-spot strategies to inspect and identify a normal functioning parathyroid gland. However, these three can be augmented by various adjuncts as depicted here. For visual inspection, the adjuncts can be of loop magnifications, NIR autofluorescence, carbon nanoparticle injections, methylene blue dye injections, dynamic optical contrast imaging, and Raman spectroscopy. To augment viability, to assess the viability of the parathyroid gland, capsular incision can be augmented by other adjuncts like ICG, NIR, laser speckle contrast imaging. For the confirmation, we can have frozen section histology and intraoperative parathyroid hormone aspirates. Coming to naked eye identification, this is the most common, gold standard, and a subjective way of identifying parathyroid gland, which is most commonly used on spot during the surgery. Has been famously quoted by Dr. John L. Doppman, which is pertaining to the parathyroid gland, that if you want to localize a parathyroid gland, uh, the best modality of localizing a parathyroid gland is to localize a best parathyroid surgeon. So, with respect to that, a parathyroid surgeon or endocrine surgeon should have a detailed knowledge of anatomy, embryology, and location of the parathyroid gland in order to preserve the parathyroid gland during the surgery also, and also during the surgery of the hyperparathyroidism. So in surgeon's experience, which is via direct visualization of parathyroid glands, it remains the gold standard of intraoperative parathyroid gland identification. Starting with the parathyroid embryology, we have 4 parathyroid glands in our body, which helps in calcium homeostasis in the body. Uh, uh, 2 superior glands and 2 inferior glands. 2 superior glands are originated from the fourth branchial pouch, and 2 inferior parathyroid glands are originated from the third branchial pouch along with the thymus. So as depicted in the image, this is after descent, at embryological descent, the superior parathyroid glands they remain in the superior one-third of the parathyroid gland, of the thyroid gland in its posterior aspect, as depicted by the shaded area here. And the inferior, as I have already mentioned, the inferior glands, they originated from the third branchial pouch. So they have to have to travel from a third branchial pouch to the inferior aspect of the thyroid glands, making them prone to more ectopic locations as compared to superior parathyroid glands. So we have to have a thorough knowledge of the parathyroid embryology in order to ascertain the proper location of the parathyroid glands, and hence preserving their vascularity during thyroid surgery. Coming to the surgical anatomy, the shape, symmetry, size, weight, and color of the gland matters while doing a thyroid surgery. In order to identify these glands from other surrounding tissues. So they are mostly spherical in shape, somewhat flattened or oval bodies. They are mostly symmetrical in 80% of the cases for the superior glands, and 70% of the cases for the inferior glands. So in 80% of the cases, they are mirror image of each other in the both the sides when it comes to superior gland, and 70% of cases in inferior glands, and bilateral for both the glands is 60%. The size of the glands of approximately 5 into 3 into 1 millimeter, with a length of 4 to 6 millimeter and width of 3 to 4 millimeter. Weight approximately 35 to 40 mg, and the color varies according to the age, ranging from gray in newborns, light pink in children, yellow color in adults, and dark color in older individuals. Coming to location and blood supply, the classical location of the superior parathyroid glands are said to be mostly in the posterior aspect in the upper third of the thyroid gland, which is approximately in 1 centimeter above the junction where the inferior thyroid artery crosses the recurrent laryngeal nerve. And the inferior parathyroid glands are most commonly located and around inferior pole of the thyroid gland, which is approximately 1 centimeter below the junction. There are various pointer in during the thyroid surgery which can point towards the probable location of the parathyroid gland. The first being the recurrent laryngeal nerve, as is shown in this picture. Both the superior and inferior parathyroid glands are related to the recurrent laryngeal nerve in a percentage sign percentage sign depiction. The superior parathyroid gland being a more dorsal and posterior to the recurrent laryngeal nerve, and the inferior parathyroid gland being more medial and anterior to the recurrent laryngeal nerve. So if you can find the recurrent laryngeal nerve during the surgery, then this can be used as a guide to the to identify superior and inferior parathyroid glands. Similarly, tubercle of Zuckerkandl can be also a pointer to identify superior and inferior parathyroid gland. Superior being the superior to the tubercle, and inferior being the inferior to the tubercle of a Zuckerkandl. Coming to the blood supply of the parathyroid glands, superior parathyroid glands is supplied by inferior thyroid artery in 80% of the cases, and superior thyroid artery by 50% of the cases. In 5% of cases, it has an anastomotic blood supply. The inferior parathyroid gland is supplied by inferior thyroid artery in 90% of the cases, and both superior and inferior thyroid artery in 10% of the cases. Hence, if parathyroid, hence these glands are a very precarious blood supply of having only end, supplied by only end arteries of the mentioned superior and inferior thyroid artery. So if the parathyroid glands cannot be located, the surgeon should attempt to dissect on the thyroid capsule and ligate the inferior thyroid artery very close to the thyroid, since the majority of the parathyroid glands receive their blood supply from the inferior thyroid vessel, which I'll be discussing in detail when I'll be discussing about the capsular dissection during thyroid surgery. Coming to difference of parathyroid gland from the other surrounding tissues like fat globules and lymph nodes, as depicted in this table. Parathyroids are mostly having a soft body that moves inside its bone fat capsule, which can be called as floating signs while we dissect the thyroid gland. They are faintly globular or oblong in shape, and if they blush on biopsy. Similarly, as compared to thyroid nodule, which are more formish in its consistency, they are more reddish in color and they don't blush on biopsy. Fat globules are friable, they are pale in color and they don't blush. Lymph nodes are more formish and more reddish as compared to a parathyroid gland. Coming to the strategies which can be used to prevent parathyroid injury during thyroid surgery. First thing, identify the superior parathyroid gland before ligating the superior pole vessels. As I've already mentioned, this superior parathyroid gland can be supplied by the superior thyroid vessel in some cases. So while dissecting, we might injure the vasculature of the superior parathyroid gland. The important concept of preserving the parathyroid gland during surgery is a capsular dissection of the thyroid gland, meaning dissecting the thyroid gland well above on the thyroid capsule, which is mostly medial to the location of both the parathyroid glands. Uh, by ligating individual tertiary branches of the inferior thyroid vessels. In this way, we can preserve the main supply of the both parathyroid glands. Another thing I want to emphasize on this, that the pattern of blood supply to the parathyroid glands, that as you can see, the inferior parathyroid glands receives its blood supply from its superior aspect, and the superior parathyroid gland receives its blood supply from its inferior aspect. So while we try to dissect out the parathyroid glands, so inferior should be dissected from its inferior aspect and the superior should be dissected from its superior aspect in order to preserve the blood supply. So this is the depiction of how a capsular dissection should be done. That we should tie the individual branches of the inferior thyroid artery well above on the thyroid gland in order to preserve the blood supply to the parathyroid gland. Another is careful selection of energy devices during dissection near parathyroid gland, as they can be injured by the lateral dispersion of the heat of various energy devices. So in this scenario, the best one to use is the bipolar cautery. So it has a minimal lateral spread during dissection, during the capsular dissection. Another important things during the surgery is that we should not vigorously rub on the parathyroid glands, or we should not try to touch or pick up the parathyroid glands during dissections. In addition to proper handling of the tissues, to have a better anatomical knowledge of the parathyroid glands, or common adjuncts which can be used to identify parathyroid gland during surgeries are loop magnifications, autofluorescence, ICG fluorescence, and carbon nanoparticles. This is the most commonly used adjuncts nowadays during thyroid surgery to identify parathyroid glands. Loop magnifications is being used most commonly by a lot of endocrine surgeons. In fact, endocrine surgeons during the surgery, which can increase and helps them easily identify the tissues into the parathyroid glands. It has a binocular loop with a 2.5 power of magnifications, which can be adjusted according to the surgeon's comfort. It can be used starting from beginning of the surgery, hence carefully dissecting and identifying each and every blood vessels and each and every other tissues during thyroid surgery. It's an inexpensive tool, and the cost was easily affordable for the surgical team. There are various studies which demonstrated that by using loop magnification, it can reduce post-operative hypocalcemia after thyroidectomy. Showing here one study which is published in 2010, which is a which evaluates the impact of loop magnification on incidental parathyroid gland removal from the pathological specimen, uh, and hence also prevents recurrent laryngeal nerve injury after thyroidectomy. Uh, it can, as shown in this table, that they have totally used 126 patients in a group where they used loop magnification, 118 patients where they used without loop magnifications. So the rate of inargumented parathyroid gland removal in the group where they use loop was 3.8 percentage, as compared to the without loop magnification group, which is very high, which is till 7.8%. And in post biochemical hypocalcemia is also lesser in the loop magnification group as compared to without loop magnifications. And also post hypocalcemia, which was 12.7% in loop magnification group and 33%, which is very high, almost more than twice as compared to with loop magnification group. There's also another study which is published in Annals of Medicine and Surgery in 2023, titling An Assessment of the Role of Surgical Loop Technique in Prevention of Post-Thyroidectomy Complications, which is a comparative prospective study. In this study, they have total two groups with loop magnification. They have taken 40 patients, and similarly same number of patients without group, where they have found a statistical significance in total intraoperative time in between two groups, which is lesser being with loop magnification. And also EBSL identifications is more in loop magnification group, and RLN identification is more in loop magnifications group. Another adjunct which is used in identifying parathyroid gland is near infrared fluorescence, which is an autofluorescence technique which uses the in situ fluorophores located in parathyroid gland. Though not proven, still been postulated that this can be CSI receptors and vitamin D receptor, which can emit lights when subjected to a specific wavelength. This is a non-invasive, rapid, light-based technique that provides real-time image of both diseased as well as normal parathyroid gland. So it is also known as optical biopsy. It uses the near-infrared techniques to identify the parathyroid glands. There are various commercial available techniques for NIRAF, as described, like probe-based techniques, image-based techniques, PDNEO2, Striker, CalSTRS, and Quest Spectrum. The most famous one being the PTI, which is a probe-based parathyroid NIR fluorescence detection technique, which uses near-infrared rays which can emit lights of 785 nanometer, which can absorb by the in situ fluorophores, and it emits light in a range of 808 nanometer to 1000 nanometer, which can be picked up by the probe, and it can be shown in the monitor, hence identifying the parathyroid glands. Another technique which is FDA approved is the Fluorobeam 800, and the newer version being the Fluobeam LX. It gives a clear image NIR fluorescence detectors. It's a basically image-based detector in contrast to a probe-based detector, which has been discussed previously. It has a sensitivity of 90 to 100% and accuracy rate ranging from 90 to 100%. Another method which is used to identify parathyroid gland is carbon nanoparticle injection. Carbon nanoparticles are nanoparticles ranging from 150 nanometer in size, and it's been given in a dose of 0.1 to 0.15 0.1 to 1.5 ml in each areas after raising the platysmal flap and strap muscle upward and downwards. It's in ultrasound guided injection of the carbon nanoparticle, confirming that it should not go into the blood vessel, and the needle were removed with a negative pressure. The area should be pressed for 3 to 5 minutes. During this time, these carbon nanoparticles, they go into the lymphatics and stain thyroid and lymph nodes, while parathyroids, they remain on stem. So it could be easily identified. As you can see in this image, the lymphatics and the thyroid, that turned into black in color, sparing the parathyroid glands, which did not take the black color of the carbon nanoparticle. Another technique which is ICG fluorescence imaging. This basically detects the vascularity of the parathyroid gland. It's the most commonly used technique, and it's FDA approved. ICG is an inert amphiphilic tri-carbocyanine dye with a peak absorption spectrum of 780 to 805 nanometer, and it emits fluorescence in the range of 820 to 835 nanometer. ICG is given externally in a dose of 2.5 to 10 mg with a T half light of 3.4 to 3.4 minute, and the imaging were taken after 30 seconds to 2 minutes, and can persist for 20 minutes. It can show the parathyroid gland can be emitted green color light on the monitor. However, it cannot be used contraindicated in pregnancy. This is a study which compares intraoperative parathyroid identification based on surgeon experience versus near-infrared autofluorescence detection, which is a surgeon-guided multi-center study. It suggests assess human factors variability through a surgeon's blinded multicentric study with PTI, using PTI. So the PTI, which obtains 95.6 sensitivity and 91.9% of specificity with 92.7 accuracy rate, with a positive predictive value of 6.9% and negative predictive value of 98.7% in identifying parathyroid glands. In contrast to that, the junior surgeons were moderately or highly confident, only identifying 77.6% of the time on whether a tissue was parathyroid or not, while the senior surgeons were moderately or highly confident in identifying a parathyroid tissue in 93.7% of the time, making it a statistical significance with p-value less than 0.0001. The confirmatory test to identify parathyroid gland during surgery is intraoperative frozen section biopsy. It identifies tissues, and it also helps in distinguish between hyperplasia and adenoma, important to parathyroid surgery. Occasionally, if there is an inadvertent revascularization of thyroid surgery, a frozen section biopsy can help us identifying the correct identification of parathyroid gland before autotransplantation. It can also give us a gross identification and cytological identification of the frozen section biopsy. It remains a highly effective procedure to discern parathyroid tissue and non-parathyroid tissue with accuracy rate of 99% of the cases. But it's very difficult to identify between hyperplasia and adenoma when we do a parathyroid surgery. Coming to auto transplantations, when there is an inadvertent injury to the parathyroid gland or devascularized parathyroid gland accidentally, we do an auto transplantation of the parathyroid gland in a vascularized skeletal muscle tissue. Before doing auto transplantation, we should confirm that this is a parathyroid tissue, not the lymph node or any thyroid nodule, which can be for the methods of auto transplantation can be of mincing the parathyroid tissue or making it to various small pieces as described by Wells. But we most commonly use the mincing of the parathyroid tissue, which is called Milroy's techniques. It's minced finely and taken into 2 ml syringe and injected into the ipsilateral tonsillomastoid muscles, following marking of the site with a non-absorbable suture or a clip. Also, a study which was done in 2002 regarding the routine autotransplantation of at least one parathyroid tissue during total thyroidectomy, which may reduce permanent hypoparathyroidism to zero, is being practiced by various surgeons in worldwide, where they routinely do an autotransplantation during total thyroidectomy. So in this study, they have taken 100 consecutively total thyroidectomy patients, where they did routine autotransplantation of one or more glands. They did one gland in 75% of 75 patients and two or more gland in 25 patients. Uh, in this study, they have selected the auto-transplanted gland in the following order. First, the inadvertently removal of the parathyroid gland, following the anatomically difficult location where they could not preserve the vascularity, devascularized tissues, and by protocol routinely they took a well vascularized tissue also. The result being that in 100 patients, out of 100, 14 patients had symptomatic hypocalcemia, 13 patients had asymptomatic hypocalcemia, which was detected biochemically. They have taken calcium values at post of day 1, post of day 2, and till the patient every day till the patient gets normocalcemic, and also another one 3 month following the surgery. So they have seen that 3 month post follow-up, they had 0% nil rate of permanent hypoparathyroidism in this group of patients. To know the functional status of the parathyroid tissue following surgery, we have post-operative PTS monitoring and also intraoperative PTS monitoring. Post-op PTS monitoring, which can tell you early prediction of the post-thyroidectomy hypocalcemia, is being practiced a lot of places, where early detection of they can do a parathyroid hormone following surgery on post of day 0 or post of day 1, and can decide if the patient is going into hypocalcemia or not. So this is a study which is published in American Association of Endocrine Surgeons in 2004, which shows early detection of the post-thyroidectomy hypocalcemia by one single IPTS measurement. Here they have, they have taken total 53 total thyroidectomy patients, and they did IPTS on day 0 to 4 on 0 hour, 2 hour, 4 hour, 6 hour, 24 and 48 hours. So they found that IPTS levels below the normal range, which is less than 10 picogram per ml at 4 and 6 hours after the operation, correctly predicted post-operative hypocalcemia and symptoms in all the patients, with a specificity of 100% and sensitivity of 94%. Overall accuracy is being 98%. Another study which was incorporated in the Australian Endocrine Surgeons Guidelines, which was published in 2007, that post-operative hypothyroid parathyroid hormone measurement and early discharge after total thyroidectomy, which is the analysis of Australian data and management recommendations. They have totally taken 458 patients, where they examined 76% of the patient had PTH in the normal range, and hypocalcemia, which is less than 2 millimole per liter, occurred in 17.9% of the patient, which is sensitivity and specificity, a positive predictive value of 92.6, 70.7, and 92.3% respectively. So they have concluded that PTS levels should ideally be drawn 4 hours post-operatively, and patients with PTH in the normal range can safely be discharged on the first post-operative day. Summarizing my presentations, the bottom line of preserving a parathyroid during a thyroid surgery is to have a better anatomical knowledge of the parathyroid glands, and to use adjuncts wherever possible, feasible, and affordable, or to augment your anatomical knowledge. However, it cannot replace the replace the surgeon's experience in identifying the parathyroid gland during the surgery. Hence, in order to prevent hypocalcemia post thyroidectomy, endocrine surgeons should have a better knowledge of anatomy and anatomical location of the parathyroid glands to use in thyroidectomy. Thank you.
Thank you, Dr. Divya. You covered all aspects of parathyroid preservation. Very nice talk indeed. And now we go on to the next speaker. Uh, she's an assistant professor from SGPGIMS, Dr. Rinal Mascarenhas. She will talk on very important aspect again, RLN preservation, and she will go take you through RLN preservation, which is very, very important.
Good evening, everyone. Sir, thank you for that introduction. I'd like to thank the organizers for giving me this opportunity to be a panelist on the topic of safe thyroid surgery. I will be talking today on recurrent laryngeal nerve anatomy and preservation. This is a very important topic for us as endocrine surgeons and for all the general surgeons out there who have logged in, and for our MCHSRs and other head and neck and ENT surgeons. So why is it important for us to study about the recurrent laryngeal nerve? It is the most common cause of medico-legal litigation for any surgeon that performs thyroid surgery. And also, this is an important question in the MCH exams. So today I'd like to cover the anatomy of the recurrent laryngeal nerve, the importance of the recurrent laryngeal nerve, what are the types of injuries, the risk factors for injuries, prevention, management, what is the prognosis and recovery, and what's new in the management of RLN injury. So we will cover the pathway function relation to the thyroid gland. So the recurrent laryngeal nerve arises from the vagus nerve, and this arises from both the sixth aortic arches. Embryologically, the sixth aortic and the fifth aortic arches, they regress. And so the recurrent laryngeal nerve recurs around the fourth arches. So on the right side, it recurs around the subclavian artery, and on the left side, it recurs around the aortic arch. On the right side, it is more lateral in location at the neck of the thoracic inlet, while on the left side, it is more straight and medial because it traverses through the tracheoesophageal groove. As it travels into the neck, where until its entry point, it will travel laterally to medially on the right side, and it crosses the ITA, that is the inferior thyroid artery, bilaterally. And that's why it's important for us to know the anatomy of the recurrent laryngeal nerve during dissection of the thyroid so that we don't injure it. There's also something called the non-recurrent laryngeal nerve, which only occurs on the right side. It does not occur on the left side. It occurs only in 1% of patients, and this occurs due to something called arterial lusoria, which is an aberrant development of the right subclavian artery. Branching. Most of the recurrent laryngeal nerves are bifurcated. So they have 60% have two branches. Some of them trifurcate, some of them have multiple branches, and about 23% don't branch at all. These are the three locations where the recurrent laryngeal nerve may be injured. One is at the ligament of Berry before its insertion into the larynx. The other is the inferior, where it crosses the inferior thyroid artery. And the third is at the lower pole, just when it enters into the neck. Most of the time, the inferior thyroid artery is anterior to the nerve. So the nerve passes behind it on both the right and left side. Around 60 to 70% of the cases, the recurrent laryngeal nerve will be posterior. But it can also be anterior and also in between the branches of the thyroid, inferior thyroid artery. And so it's important that during dissection, we ligate only the branches of the inferior thyroid artery and not the nerve with the artery. So what is the importance of the RLN? It provides motor, sensory, and integrated functions. The motor function, it provides function to the intrinsic muscles of the larynx and the vocal cords, except the cricothyroid muscle. It provides vocal cord movement in speech, singing, pitch, and tone. It also has sensory functions to the larynx and the mucosa of the lower larynx. Integrated functions include swallowing, cough reflex, voice modulation, and breathing. And like I said in the beginning of my talk, that the RLN injury following thyroid surgery is one of the leading reasons for medico-legal litigation against surgeons. So what is the type of RLN injuries? It can be transient, it can be permanent, it can be unilateral or bilateral. Permanent injuries can occur in about 0.3 to 5%. Transient palsies can occur in about 5 to 8% of cases. And this is just those that are recorded on post-surgery examination. However, subjective post-thyroidectomy voice complications can occur in up to 87% of patients. So in thyroid surgery, around 1/3 of patients have iatrogenic unilateral vocal cord palsy and 80% have bilateral vocal cord palsy. However, most of these studies have been done in the US, where around 50% of surgeons in the US perform only one thyroidectomy per year. So what is the mechanism of injury? It can occur due to transection, blind clamping, ligation, traction, thermal injury, and even ischemia. So it's important for the first assistant who is medializing the gland to make sure that they don't over medialize the gland, because that can cause tenting of the recurrent laryngeal nerve at the ligament of Berry and may cause injury. I don't have to go through this. These are the grades of injury. It can be neuropraxia, axontemesis, or neurontemesis. So what are the risk factors for recurrent laryngeal nerve injury? Mostly it happens in patients who have malignant disease with invasion into the nerve. Graves' disease by itself is an independent factor for RLN injury. Even thyroiditis due to adhesions, a large goiters with retrosternal extension, any reoperative procedure with distorted planes or difficult identification, if the patient is being re-explored for bleeding, and some miscellaneous causes can be in low volume centers where less than 150 thyroidectomies are performed per year. If there is long OT time, increased blood loss. And some intraoperative considerations are if there is lack of knowledge of the normal anatomy, like we mentioned earlier, the right side is more oblique, the left side is more straight. If there is heat electrocoagulation, dissection close to the nerve, stretching, and non-identification of the nerve. A Danish study of 7 years in around 6,000 odd patients showed that there was a relative risk of 10% injury to the recurrent laryngeal nerve in patients that underwent re-surgery. So that is why your first surgery should always be your best surgery. This was a study published in the American Journal of Surgery. It was a database analysis on what were the factors associated with RLN injury. And they also had similar results. Patients that were older in age, black race, had malignancy, underwent total or subtotal thyroidectomy, any concurrent neck node surgery, a long OT time, were all factors for RLN injury. Like I said, post-op outcomes in Graves' disease. This was a inpatient nationwide sample database, which also showed that Graves' disease was independently associated with a higher risk of vocal cord paralysis with an odds ratio of 1.36. This similar study on patients that were operated for thyroidectomies that used IONM or intraoperative neuromonitoring also had similar risk factors. So patients that had malignant goiters, recurrent diseases, all these patients had a higher risk of RLN injury. So coming to, if you can see in red, those are the highest associations of patients that have RLN injury. That is an atypical course, an intrathoracic goiter, redo surgery, low surgeon experience, and atypical RLN anatomy. These are most common causes for RLN injury. So how do we prevent it? So the most important rule to follow is that no structure is cut until the recurrent laryngeal nerve is identified visually and or electrically. Now I'm saying and or electrically is because in most of the developed countries, they use intraoperative neuromonitoring. It is allowed by their insurance companies. The insurance companies pay for it. And so by default, they do use this. In our country, it is very expensive. And so we save the use of intraoperative neuromonitoring only for difficult cases or in reoperative cases. So the preoperative considerations would be we need to first improve our preoperative assessment. So that's why we always perform an indirect laryngoscopy prior to surgery. As Randolph had reported that around 70% of all invasive thyroid diseases and around 0.3% of benign diseases had preoperative defective vocal cord opposition. So if we document that these patients have already had vocal cord palsy before, it can save the surgeon in litigation post-operatively. The intraoperative considerations are identification of the recurrent laryngeal nerve in its anatomical course and capsular dissection. This was given by Lahi and Riddle. The terminal 2 centimeters of the extralaryngeal recurrent laryngeal nerve is the most common site of injury because of traction and branching. The medial or the anterior displacement of the nerve can occur in large goiters and needs to be kept in mind. Sometimes there can be non-recurrence of the nerve on the right side, like I mentioned, and that also needs to be kept in mind. This was the surgical management of the recurrent laryngeal nerve in thyroidectomy was given by the American Head and Neck Society consensus. This is a nice table that is given in Randolph. We mostly do the lateral approach in all of our cases, but there's also an inferior approach, a superior approach. And we had also published a medial approach to the identification of the recurrent laryngeal nerve, which is 4 steps. First is the isthmus is divided, and the cut edge of the thyroid is grasped with a Babcock. Secondly, the medial portion of the thyroid is separated from the cricothyroid muscle and the trachea, and the Berry's ligament adjacent to the first tracheal ring is left intact. Thirdly, the median thyroid space is opened. And the fourth and most critical step is that the Berry's ligament lateral to the first tracheal ring is retracted and the recurrent laryngeal nerve is identified there and dissected as it courses deep into the superior edge of the ligament. We also had a modified medial approach where the recurrent laryngeal nerve is identified at the point of insertion into the larynx. So the optional equipment, and I'm specifically mentioning optional, is because nothing can, you don't need to use intraoperative neuromonitoring if your anatomy is good. So nothing can help you prevent recurrent laryngeal nerve injury if your anatomy is not good. So the goal of intraoperative neuromonitoring is to reduce the rate of RLN injury, and the benefits were significantly reducing iatrogenic RLN injury. It increases the surgical safety. It improves the identification rate of the RLN. It also accelerates intraoperative RLN identification and reduces accidental injury. It defines the relationship of the anatomical structures and nerve function, and it also defines the position of the damaged spots of the nerves. This is an image of our neuromonitor in our OT. And we usually use it in reoperative cases in large or retrosternal goiters and in locally advanced thyroid cancers. Like I said, IONM cannot substitute for detailed knowledge of neuroanatomy, intraoperative visual identification of the recurrent laryngeal nerve, and meticulous surgical technique. So this was a systematic review and meta-analysis that showed that there was no difference in recurrent laryngeal nerve injury in those patients that had IONM usage versus only nerve visualization. Coming to continuous versus intermittent intraoperative nerve monitoring, continuous is when there is an electrode that continuously stimulates the nerve that can tell you about the nerve health. So in this case, in thyroid surgery, the vagus is continuously stimulated. So if there is traction on the nerve, it usually tells the surgeon, and so you can change your maneuver and prevent traction and prevent injury, versus in intermittent neuromonitoring, you will only find out after you've cut the nerve, or maybe only when you stimulate the nerve. And in that case also, you have to identify the nerve first to be able to stimulate it. And this also showed that there was no statistical difference between continuous and intermittent neuromonitoring. The American Association of Endocrine Surgeons put out a guideline on the management of thyroid disease in adults, and they recommended that while it does not prevent RLN injury, IONM is safe and may assist the surgeon during initial or reoperative thyroidectomy with a strong recommendation and moderate quality evidence. Coming to the role of energy-based sealing devices around the nerve. So monopolar cautery has a lateral thermal spread of 3.5 mm. The least is the harmonic scalpel. So around the nerve, we usually use either the bipolar, the ligashore, or the harmonic scalpel, and not the monopolar cautery due to this due to the lateral thermal spread of the monopolar cautery. The RLN injury rates are similar to conventional. Also, a study of the use of IONM in thyroidectomy in the American head and neck surgeons, the American ENT surgeons, and the International Association of Endocrine Surgeons. And they showed that 83% of those surgeons use IONM in their thyroid surgeries, and they recommend IONM. However, this is only a level 4 evidence, which is only expert opinion. So that comes, then we can ask ourselves, what about endoscoping and robotic surgery? Can RLN injury occur there? And a study was done in Korea that showed that the use of IONM in identification of the recurrent laryngeal nerve had it has similar safety reports versus open, robotic, and endoscopic, which is less than 2%, which is acceptable. Coming to the 12 commandments or practical points of management of the recurrent laryngeal nerve while dissecting during thyroidectomy. The first one is don't see and don't cut rule. This is the most important rule. If you do not see the recurrent laryngeal nerve, if you cannot see it visually through any transparent fascia, make sure that you do not cut that fascia. If the nerve versus the parathyroid competes for your surgical attention, the nerve always wins because the parathyroid can always be auto-transplanted. We should always confine our dissection to the anterior surface of the trachea because the lateral surface of the trachea can always have the recurrent laryngeal nerve that may be tented up and we may cause injury. We always have to watch the nerve as we retract, as it can cause neuropraxia. Anterior delivery of the thyroid is risky because, like I mentioned, the nerve can be tented laterally and may be injured at the ligament of Berry. We should always keep the nerve under direct vision. The anterior arch of the cricoid cartilage in the midline is a superb landmark for the recurrent laryngeal nerve. After completion of surgery, imprudent suction and aggressive use of gauze or small rolled peanuts should not be done, because if you've done the effort to save the nerve, and then with suction that can cause neuropraxia, or gauze can cause neuropraxia, and then all your effort would be wasted. Bipolar cautery near the nerve should be used with extreme caution and for limited time because of lateral thermal spread. Attention to the distal segment of the nerve, because the nerve can bifurcate very distally at the thoracic inlet. So we need to know about the bifurcation so that we can save the anterior branch more than the posterior branch, because the anterior branch is motor. If the distal nerve looks thin, go back down and redissect it to exclude branching. And beware of a large posterior branch, that's a sensory branch, because we may injure an unidentified anterior branch at the ligament of Berry. Coming to the management of RLN injury, intraoperative considerations are, if we suspect that there is nerve paresis, immediately after extubation, we can check for whether the patient has altered respiratory status, stridor, or aspiration of secretions. Based on the severity, we can either observe, or we can give supportive measures like humidified oxygen or adrenal nebulization. We can elevate the head end of the patient, give steroids, CPAP, re-intubate, and rarely tracheostomy. Most of the paresis is transient, and the patient's voice becomes normal after 2 weeks. So these are the positions of the vocal folds, and the vocal symptoms are more if the distance of the paralyzed vocal cord is further from the midline. For unilateral recurrent nerve palsy, hoarseness is more common, and occasionally it can also be asymptomatic. It does not obstruct the airway. The patient will not present with stridor. The immediate thing that we can do intraoperatively if we have injured the nerve is re-innovation procedures. Early, if we have found out after the surgery, early management can be glucocorticoids or vasodilators, and also voice training, and that is speech therapy. Delayed management can be injection of bulking agents, thyroplasty, and arytenoid adduction. So intraoperatively, most commonly what we would do is an end-to-end anastomosis. But if the sections are too far away, we can also use the ANSA or the greater auricular nerve or the vagus and other interposition grafts. The advantages is that the adductor muscles will have innervation and it will prevent atrophy. So direct anastomosis is done when there's a gap of less than 5 millimeters. And cable grafts, there are multiple tests that we can do post-operatively. Like I said, early treatment can be given with glucocorticoids. DEXA can be given, dexamethasone, or a single IV hydrocort 100 mg can be given immediately post-op. But data shows that this does not change the management or does not help the patient with a early voice recovery. Intraop, like I said, there was no difference in the rate of palsy between corticosteroids and the placebo group. Something that can be tried and is new is adjuvant nimodipine, which is a calcium channel blocker, and that can decrease the collateral reinnervation and increase the recovery of the recurrent laryngeal nerve. Neurotropic drugs like vitamin B12, there's no data as such specifically on recurrent laryngeal nerve, but it has shown to improve nerve regeneration and may be tried. Voice therapy can be given, like I mentioned. Other agents are injection laryngoplasties for medialization of the vocal fold. Thyroplasties are also done. What we do post-thyroidectomy is a medial thyroplasty. Other surgical options are arytenoid adduction and cricothyroid. This is a management algorithm. So in unilateral recurrent laryngeal nerve paralysis, it work with the patient. If the patient is symptomatic, patient has respiratory difficulty, pneumonia, poor voice quality, we can do medialization of the vocal cords. If the patient is symptomatic but is well tolerated, we'll follow up for up to 1 year. And then we'll reevaluate. And if the patient has persistent symptoms or has poor quality of life, then we can perform medialization or thyroplasty techniques. Now, what are the manifestations of bilateral recurrent laryngeal nerve injury? These patients present with severe upper airway obstruction and stridor. And these patients, sometimes there can be delayed stridor also. They have a breathy voice first, and then it'll get stronger once the airway becomes worse. So you can see in this image, there's an open airway on the left, and on the right is a completely closed airway due to bilateral laryngeal paralysis. So what is the management? The gold standard is a tracheostomy. So the three main categories are static procedures, re-innovation, and electrical pacing or CPAP. So in the static procedures, our attempt is to enlarge the airway, and this can be done with a tracheostomy, chordotomy, laser arytenoidectomy, and suture lateralization. The others are re-innovation. This has limited success. And also electrical pacing, where the vocal cords are electrically stimulated, which coincides with respiration. What is the prognosis and recovery? In partial injury, the nerve function usually recovers within a few weeks. How do we define a transient palsy? Most of our cases will recover within 4 weeks. So transient palsy is less than 1 year. Donigi et al. Reported that 89% of partial palsies were resolved within 1 year. If there is ongoing dysfunction after 1 year, then it is diagnosed as permanent recurrent laryngeal nerve palsy. And Struer et al. Had reported that even up to 2 years, the recurrent laryngeal nerve can take to restitute function. So what is new in the management of recurrent laryngeal nerve injury? There's also tissue engineering technology. Human chorion membrane has been used. Other things like nerve guide conduits, hydrogels, also stem cell technology has been used, and it has shown promising results in animal studies with improved vocal cord function. So my take-home points would be prevention of injury with knowledge of neuroanatomy of the recurrent laryngeal nerve, and to avoid traction and compression injuries. Thank you.
Thank you, Dr. Rinal. Very informative, and you also covered all aspects of RLN injury, and as you rightly emphasized as well, like this is a very important thing for MCH postgraduates as well, like who are there, the young Turks, young
Yes, sir.
warriors. So, and thank you again. And we come back to questions at the end. And now,
Thank you, sir.
okay, thank you. And then we invite last speaker to talk about one of the important aspects of thyroidectomy, robotic thyroidectomy. Shall we have Dr. Madhu to speak on robotic thyroidectomy? She is an assistant professor at SGPGAMS. I request Dr. Madhu to give her talk on robotic thyroidectomy. Dr. Madhu Kumari, is she there around? Okay, till Madhu joins, we'll try to call her. If at all anybody has any questions.
Good evening, sir.
Good evening, Madhu.
Good evening, sir. Good evening.
Okay, so Dr. Madhu Kumari, she's an assistant professor at SGPGMS.
Yes,
She
sir.
will talk
I'm
about.
sharing my slides. First of
Sure,
all, I
sure.
would like to thank Association of Surgeons of India and Association of Surgeons of Rural India, giving and whole the organization for giving me opportunity for this discussion. Uh, 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 um, Yes. Is this visible to everyone? My
Yes,
slides
Madhu, your
visible to
slides are
everyone?
visible. Visible. Very, very nice.
Hello?
Yeah, it is visible.
Visible
Hello?
presentation.
So I'll discuss today. I will discuss robotic thyroidectomy, and among them, in which I'll discuss what is robotic thyroidectomy, short introduction of robot, how we'll select patient for this procedure, and I'll show a small video in a case. At the end, I will discuss advantage and disadvantage of robotic thyroidectomy along with literature. What is robotic thyroidectomy? Robotic thyroidectomy or robot assisted thyroid surgery is a minimally invasive technique that utilizes robotic
Please
system
the
for
presentation
improved visualization,
format.
enhanced dexterity, and for less visible scars. So, what is robot? First time robot term were used in a science fiction written by Carol Capek in Rossum's Universal Robots. So,
Madhu,
character
your slides are not moving.
interested in studying the marine biology, who invented a substance like organic matter through which he made thousands of robots. And that robot were used in industrial industry to overcome burden of the labors. And this over a time. Sorry for interruption. So this robot boosted the economy of that time. But in contrast to the robot that were used in the surgical field, that primarily used for the minimally invasive surgery to eliminate the unwanted hand of tremor and for the remote surgery. So history, coming to the history of the robotic thyroidectomy, first robot. Okay. Uh,
Madhu, are you sharing your
दिख नहीं रहा है.
अच्छा
That's good.
तो
हाँ.
मेल करो
मेल या मुझे इस पे दो.
किस पे
Okay, till they are sorting out Dr. Madhu's issue, 2, 3 things we will ask our final years are there. Dr. Prachi, are you there? Dr. Prachi? Okay, she's not probably. What? Actually, Dr. Mithilesh is there. Mithilesh, are you there?
Yes, sir.
Okay, so you have any queries to any of the like any of the presentations which have been finished, which have finished?
Very nice presentation, sir, by all our seniors.
Okay.
I would like to ask Dr. Enel, that how do you balance the benefits of using a routine intraoperative nerve monitoring uh, with the basically, is there a risk of false negative signaling in the surgery? Because we usually do so in case of preoperative surgeries here. So is there any chance of false negative signaling? How do you prevent those things in case of recurrent laryngeal nerve monitoring?
Thank you, Mithilesh, for that question. So there are false negatives. In that, we have to restart the monitor. I would have to go into full detail about how the neuromonitor works and where we need to recharge and reboot the monitor to check whether there is a false negative. So in this case, what we usually do is we stimulate the vagus first. If the vagus is getting stimulated and the recurrent laryngeal nerve is not getting stimulated, that means we know that our intra-op neuromonitor is working. If the vagus is also not stimulated bilaterally and the RLN is not stimulated bilaterally, then we need to check our electrodes. It must have been displaced. Our grounding may not be working. There are a lot of very technical things that we would have to get into, which I would not be able to cover here.
Oh, thank you. Thank you so much, ma'am.
Okay, thank you, Mithilesh. And any questions? Dr. Rajni is there. Dr. Rajni, you want to ask any question? Dr. Meenakshi? Dr. Namrata? I have one question, this one, like Dr. Spandana had covered regarding surgical smoke. And so is it different in different instruments or almost the composition is same?
Thank you for the question, sir. So the literature that I came across, I could not find any difference between any study that has gone into the depth of this issue. But what I did come across was that even though they were not able to establish whether the surgical smoke itself is causing any long-term effect in the operating team. They have derived these conclusions by all the other studies in postmenopausal women who, if they were exposed to prolonged air particulate pollution, then they could develop cardiovascular as well as respiratory troubles. So
Thank you so much. Yeah, it's a difficult thing, but most of the smoke are similar, is it not?
Yes,
That's
sir.
what. Yeah, but as you rightly pointed out that. So now I think Madhu is presenting from Rinal's thing. So actually,
Yes, sir.
we go back to the presentation.
Yeah, so, sir, good evening, sir, and thank you, Dr. Enel, for this
Sure,
one.
sure, Madhu.
So, overview, but I'll discuss what is robotic thyroidectomy and short introduction of robot and how we will select a patient for robotic thyroidectomy and a case in which I'll show a small video of this procedure. At the last, I will discuss advantage and disadvantage along with the literature. What is robotic thyroidectomy? Robotic thyroidectomy or robot-assisted thyroid surgery is a minimally invasive technique that utilizes robotic system for improved visualization, enhanced dexterity, and for less visible scar. So what is robot? The term robot was first used in a science fiction written by the Carol Kepek in the Rossum's Universal Robots. The character young scientist Rossum invented a substance like organic material through which he made thousands of robots, and that robot were used in industry for the purpose of overcome the workload over the laborers. And that this use of over time, this use of robots in the industrial area, they boosted the economy. So we can say robot is a forced laborer and who didn't have own thoughts. But in contrast to this, in the surgical field, robot is primarily used in the minimally invasive surgery to eliminate the unwanted tremor of hands and for the remote surgery. So coming to the history, a first robot that were used in surgical field was Puma 560 for the stereotactic neurosurgical biopsy, and then many more robots has came into the picture like Probot, Robodoc, Da Vinci, and Zeus. Zeus was the Zeus last this one having potential for the remote surgery, but not available unfortunately. And Da Vinci has come with the many generations. So first generation was Da Vinci Standard or Da Vinci Classical, and that eliminates the whatever difficulty we are facing in the laparoscopic procedure. Second generation was Da Vinci S, high definition, and that first time utilizes the 3D high definition SI, and that first time used the double console options. Fourth generation Da Vinci XI, many more has come. In 2024, it earns the FDA approval. In our institute, we have Da Vinci XI fourth generation, and it has 3 parts. The patient side and patient side have 4 arms, 2 or second and created 3. Rest of the arm 1 arm instrument resembles the movement of our wrist, and that gives freedom of dissection. Second part of this robotic system is vision part, and this is actually brain of the robotic system that manages 3D vision and communication. It processes images from endoscope and transmits to the surgeon console. And many advanced features, and it has many advanced features. Third part is surgeon consoles, where surgeon is sitting on the chair, holding this clutch with the help of fingers, and foot is at foot pedal. Now we can see the settings of this robotic system inside the OT. So this picture is from our OT. The patient is under general anesthesia. Well positioned. This is the patient side cart having 4 arms, arm to holding the camera, rest of the arm holding the instruments, the vision card, we can appreciate the surgeon sitting at the console where foot is at the pedal, arm is holding the clutch, eye is in the eyepiece of the console. Surgeon's comfortable and throughout the when he is performing the surgery. The movement of hands after filtering and scaling down the hand movement, this movement of hand is translated into the arms movement, and so in short, like the approach of the thyroidectomy. Thyroidectomy, as we all know, the conventional or open thyroidectomy or minimally invasive thyroidectomy. Minimally invasive thyroidectomy through a small incision in suprasternal region, and performing thyroidectomy with the help of camera is also called as a minimally invasive video-assisted thyroidectomy. Rest all are endoscopic or robotic, where incision is given away from the front of the neck, like in the lateral aspect of the neck, that is called cervical, or in the mucosa of the vestibule. This is called a transoral, where we put a 3-port. Center port is camera port, and 2 is a working port, and we approach the thyroid glands from above side. Actually, this transoral is truly scarless, as mucosa heals without leaving any scar. Rest are anterior thoracic, axillary breast, that we will see in next slide. So first, we would put 2 ports in each complex, and 1 center port for the camera in the pre-external region. But we all know this pre-external region is notorious for ugly scar, hypertrophic scar, or keloid formation. So we shifted this pre-external camera port to the one of the axilla, and now this 2 nipple areola complex port, 2 breast port, and 1 axilla is called axillo-bilateral breast approach. Third approach is where approaching the thyroid gland through the 2 breast and 1 axilla, so covering 3 quadrant of the breast, the chest area. So we shifted one of the breast port to ipsilateral axilla, so that become unilateral axillo breast approach. So it minimizes the dissections or dissection in opposite side of the thyroid nodule. Another last approach is by putting this 1 extra port in the opposite axilla. So 2 breast port, 2 axillary port in each axilla. So we have now 4 port. So 2 working port, and 1 is camera port 3, and 1 extra port that helps in traction and counter traction during dissection. That also help in suction on all. And we can also appreciate this by reshuffling the camera port from the one breast port to another breast port. We can see both the thyroid gland at a time, so we can perform total thyroidectomy simultaneously, and also we can perform dissection in center part of the neck and bilateral lateral neck lateral compartment of the neck. So this approach, bilateral axillary breast approach, become popularized, become more popular, and also suitable for total thyroidectomy or thyroid cancer where neck dissection required. These approaches can be done without gas insufflation or with the CO2 insufflation, where pressure should be kept 5 to 6 millimeter of mercury and flow rate should be 2 liter per minute. But again, this depends upon the surgeon's discretion. The pressure can be raised up to the 8, and flow rate can be increased up to the 6 or 7 liter per minute. Now, how we will select a patient for thyroidectomy? So, as per American Thyroid Association guideline, the management of thyroid nodule, indication for thyroidectomy should be the same as for conventional surgery. But the ideal patient is a patient with a small thyroid nodule and who is motivated for a scarlet neck surgery. But I can say that the actual indication depends upon the surgeon experience. Although robotic thyroidectomy has some absolute contraindication like substernal retropharyngeal goiter and thyroid cancer with extra extension and medullary is absolute contraindication for the robot thyroidectomy. And there's a relative contraindication. And that again depends upon the surgeon's pains and surgeon ends and the patient keenness for the surgery. These are the modifiable and can be increased up to the size module up to the 8 centimeters. With anterior neck swelling without any family history. On examination, we will arising from the left lobe of thyroid with a smooth surface, well-defined margin, form consistency, intact mobility of the thyroid nodule, moving up with deglutition and located in the lower part of neck in the right side, in the left side of the neck. Biochemically as well as clinically, patient is euthyroid and neck ultrasonography showing 63 into 40 millimeters solid nodule with post calcification, thyroid scoring 4, and guided FNAC from the left solitary thyroid nodule showing ATP of undetermined significance with HESTA category 3. So with the diagnosis of left thyroid nodule, we have, and with the patient is keen for the scarlet neck surgery, so we have plan of left robotic hemithyroidectomy through bilateral axillobreast approach in view of large size. So now I'll show video. So first few second video is taken from another patient of MNG just to show the markings. So this is the midline bilateral sternocleidomastoid muscle is marked, and this is bilateral clavicular marking 4 centimeter below the bilateral clavicular marking, and parallel to them is another dotted line is given, and these 4 are the port markings. 50 to 70 ml of total solution of 2% xylocaine, adrenaline, and Ringer's lactate were infiltrated at the marking site. The marking site, and then after infiltrating this solution, we put a small incision on both the nipple areola complex, and then we use a straight short artery creating a tunnel at the previously given marking line, and then uses curved long curved artery and then tunnel. By blunt dissection, we create a small space in the pre-external region. Then we put 2 ports. One is a camera port and another is instrument like monopolar cautery. And we created a space in just below the bilateral clavicular line. And under vision, we will put 2 axillary port. And after putting all the 4 port, patient were docked with the robotic arms. And then patient handed over to the surgeon who were sitting at the console. And then flap in the neck just above the bilateral clavicular line, the suprasternal notch, and superiorly raised up to the superior border of thyroid cartilage. And after completing this flap, then like the open thyroidectomy, we open the median raphe of strap muscles, and then superficial layer of strap muscles, sternohyoid, is separated from underlying structure, followed by the posterior layer of strap muscles, that is sternothyroid separated from underlying thyroid nodule. A glistening surface were visible. This is the glistening surface of the thyroid gland. This is actually plane that Fareen ma'ams were discussing in the first few minutes. This is the actual plane where the dissection should be performed. This is avascular plane. And after that, in the open thyroidectomy, we approach the superior polar vessels. But in robotic thyroidectomy, this is different. First, after exposing the, separating these strap muscles and creating the going up to the lateral aspect of the thyroid nodule, first we cut the isthmus. And then after this, this is the glistening surface of the thyroid nodule and separating the strap muscles. And then after completion of this separating completely till above and down, first we cut the strap, the isthmus, just separating the lateral aspect of this thyroid nodule. Then after cutting this isthmus, the trachea on the lateral aspect, anterior and lateral aspect is separated till the ligament of Berry. Now, second step, which is different from open thyroidectomy, is the thyroid nodule. Now we approach thyroid nodule from downside, from the inferior surface of the thyroid gland. And we will look for the recurrent laryngeal nerve. In the open thyroidectomy, we search the recurrent laryngeal nerve in the lateral aspect of the lateral. We would like to search recurrent laryngeal nerve just below the thyroid nodule. After holding this thyroid nodule up with the prograsp that we will do after separating this lateral aspect of thyroid nodule, here we can appreciate this crystal clear image of this robotic. And now we are searching for recurrent laryngeal nerve. From the inferior aspect, this is the progress that is holding this thyroid nodule. This is monopolar energy devices, and this is the bipolar Maryland, and we are searching for recurrent laryngeal nerve. And after visualizing this recurrent laryngeal nerve, our plane of dissection remains the pretracheal fascia and a direction from down to upward. Here we can appreciate the movement of this endorest that gives a freedom of 360-degree dissection. This is recurrent laryngeal nerve. Just we will see this is, and then dissection will proceed from down to upward. Third difference from the open thyroidectomy is that we will deal this superior polar vessels at the end. So now we are first we are dealing this separating the Berry ligament, and then we'll deal this superior polar vessels with the help of bipolar and monopolar energy devices. This is the plane of dissection. One thing I want to say here, by sticking this plane of dissection at the pretracheal fascia, our parathyroid and recurrent laryngeal nerve remains uninjured. This is the actual plane, and this is also bloodless surgery that we can appreciate. The thyroidectomy and the robotic thyroidectomy is almost clear field, having a clear field. After dealing with this superior polar vessels, we will remove this specimen. Actually, a specimen will removed with the help of endo bag that is available, but to cut short the cost of the surgery, we use the gloves for the removal of a specimen. Now, this is the superior polar vessels that we cauterize with the help of bipolar, and from the medial aspect by the monopolar energy device. This is the polar vessels, superior polar vessels. This is superior polarization that we will do at the end. We will at the end, and this is how a specimen is free. This is at end of the thyroidectomy. Now this specimen is free. After we'll remove this specimen through the right ASRI port, and then we will put a hemostatic agent in the median raphe of strap muscles. This we are removing this. This is the endo bag that is made by us with the help of this gloves. This is from the right axillary root. This is hemostatic as the help of Grill 30. After completion of this closure of median raphe, we will put a drain in the lateral thyroid space. So now at the end, I'll put a small drain, and usually this drain stay for 2 to 3 days, and then we will remove. Not for the this drain is just to prevent the seroma formation, as dissection area is large from the pre-external to the superior thyroid cartilage. So after 2 to 3 days, we will remove this drain, and patient will discharge before that or along with the in situ drain. This is putting the drain, and we can apply move at the 360 degree, any degree. This is the reliance of the movement. So now patient were discharged on the post-operative day 3, and post-operative period was eventful, and grossing left thyroid node gland was 53 gram in the weight and 7 into 4.5 centimeter in dimension. Final histopathology is coded as a follicular adenoma, and now we have seen many advantages of the robotic thyroidectomy, but it still has some disadvantages too, like expenses, and we have to accommodate this large instrument inside the operating room, and we have to take care of sophisticated instruments, and last we have to be trained ourselves, myself, for robotic thyroidectomy. So we have left with the question, is this robotic thyroidectomy safe for open thyroidectomy, or what would be the complications? Is complications higher than the open thyroidectomy or less than open thyroidectomy? And is this robotic thyroidectomy is oncologically safe or not? So to answer these questions, I went through the literature, and one paper published in robotic thyroidectomy by bilateral breast approach. This is this paper published in 2013 in surgical endoscopy, and that this article studied more than 1,000 patients. All the underwent robotic thyroidectomy for thyroid cancer. And they quoted that robotic thyroidectomy, and they concluded that robotic thyroidectomy as effective method that provides good surgical completeness and low rate of postoperative complications and risks. Another study that robotic thyroidectomy for thyroid carcinoma and know how to prevent them can perform robotic thyroidectomy safely. Another paper that was published in same journal in 2017. This is actually a systematic review and meta-analysis, and this meta-analysis included more than 20 articles and more than 5,000 patients. This also concluded that robotic thyroidectomy is as safe as open thyroidectomy for the treatment of thyroid cancer based on the long-term follow-up, surgical completeness, the adverse events and complications, and recurrence rate of robotic thyroidectomy were comparable with open thyroidectomy. So we can say the robotic thyroidectomy is as safe as open thyroidectomy. And we have our experience. Our institute is also performing robotic endoscopic robotic therapy, and we have published many papers. Few of them are. And our robotic thyroidectomy is equally effective in terms of oncological as well as so concluding that robotic and patient ratio can and out is similar to the open thyroidectomy.
Thank you, Dr. Madhu. That was a really nice talk on robotic thyroidectomy and a very great video as well. And so we have completed all talks. It is almost 2.5 hours now. So I don't I request Dr. Fareen to join me, and then if Dr. Fareen, is she there?
Yes, I'm here, sir.
Uh, Sorry we disturbed you on a Saturday with 2.5 hours, but
No problem, sir.
like
It was a great academic
yeah,
discussion.
it was very nice to relearn many things, is it not actually? And then
Absolutely,
anybody,
absolutely.
first let Dr. Farin give her comments, and this one regarding the topic, then we'll take questions.
Sir, it was great, extensive discussion by all the speakers. Had barely touched very superficially. They've done a remarkable job. All I want to say is, especially, especially because of what Mithilesh had asked about false negative signals in monitoring, nerve monitoring. I just like to say that at the stage where he is right now, MCH, I think he should focus more on the
Okay.
Okay, am I audible?
Yeah, now you are audible, Farid.
Yeah,
Yeah,
yeah. So I was telling about Mithlesh's doubts. I would just request him to focus on the anatomy and dissection during surgery rather than thinking about using it as of now at this present MCH level. I'm not sure if routinely it's being used even during training. It's only often used during reoperative surgeries.
yeah. Yeah, I agree with you. See, actually, we all have learned that way, is it not? We never had the
Yes,
luxury of nerve monitoring, and then at some point you have nerve monitoring, and then it does help actually in certain situations. Otherwise, as you
yes,
rightly
yes.
pointed out, like, and our training, like all of us, most of us in this uh, who are participating in, at least in Zoom, are from the same institution and
Mhm.
the same kind of training, is it not,
Yes,
to
yes, yes,
preserve
yes. Even
to have an anatomical idea. and
hmm,
and one more point is, like, preserve every parathyroid as if it's the last parathyroid on earth. Actually, that is the
absolutely,
classical
absolutely,
teaching
sir.
there. So that is what we are taught, and the youngsters who have joined will greatly benefit from your and all the four other panelists also, because the young generation have to realize that to do a thyroid surgery, you need to have that being, I'm a thyroid surgeon, I will do it
grasp of
justice.
anatomy. And open thyroidectomy is a must to master even when you really want to do robotic thyroidectomies in future, because the principles are same.
Yeah. Now you do robotic also, no? Sorry.
Sir, I have been assisting. I've not done anything
Okay, that like
independently.
this one, what I'm trying to say is like, as she rightly pointed out, you need to be like, you need to understand the anatomy and you need to do good to open thyroidectomies at least, is it not? Like before you embark on endoscopic and robotic stuff.
Yes, sir. Yes, definitely.
And we invite the other panelists also, like Dr. Spandana, you need you have something to say?
Uh, this these series of talks that we had are very important, especially for the upcoming MCH endocrine surgeons, who I can see many of them are logged in. Performing safe thyroid surgery is paramount, and all the panelists have described on how it can be achieved. And what can be seen is that having a good surgical knowledge is the basic way of achieving that. So I think the new generation should really focus on knowing the basics and then move on to knowing and experiencing other innovations that are coming up.
Thank you so much. Actually, next we ask Dr. Divya is there. Dr. Divya, you want to say something? I think she's not there.
Sam, yes.
So okay, sorry. Actually, I am looking at Divya and Spandana is talking. Okay.
Uh,
Yeah, please.
First of all, thank you, sir.
Mm.
It was a great session. All the talks are something to learn from. As everybody had already pointed out, that we need to stick to our basic. And when it comes to a surgery, which is like thyroid surgery, which is kind of for us, it's a surgery for us. It's an important surgery for us. We need to have a very good idea about anatomy, and that was perfectly covered by ma'am. It was a really presentation, and similarly all of my colleagues have also given their part of the topics very nicely. So thank you so much, sir. I have also learned a lot of things from my colleagues, which what they have presented. Thank you.
Thank you so much, Dr. Divya. Now, Dr. Rinal, actually, when she said the introduction itself was so like I do not have a word to say, like it was intimidating for MCHPG. Like this was asked many times in the exam, which is true also. So, Rinal, your take. And one more thing you pointed out, for any oncology or surgical oncologist or a head and neck surgeon or an ENT surgeon. So, uh, any thoughts on who should do thyroid surgery and things like that?
So I actually wanted to, this talk was for everybody who is doing thyroid surgery. So whether that
Yes.
is an endocrine surgeon or any other surgeon, um, basics. Anatomy is the most important. And we may have different degrees to our names, but at the end of the day, patient is patient, thyroid is thyroid. And it's important that we know our anatomy.
Yeah, that's a great one. Like actually, as you said, if you want to do thyroid surgery, you might have an ENT background or a surgical oncology background or a head and neck background, whatever be the background, the principles will remain the same. And we need to preserve at least two things, is it not? Parathyroid and
Yes,
the
sir.
nerve.
Yes, sir.
Because that is very important. Because see, actually, uh, things do not belong to single, even though we will like this one, because everywhere there is sharing, like see, for example, carcinoma breast, oncologist will operate, general surgeon will operate, endocrine breast surgeon will operate, breast surgeon will operate, and things like that. So similar is with thyroid will have lot of things, but if we have to do something which is very safe, we have to do. point very well said. Okay, thank you, Renal. And
Yes, sir.
Dr. Madhu.
Thank you, sir.
Okay. Dr. Madhu,
Yes, yes.
you want to say something about this panel?
This is Dr. Mehta. Can I interrupt?
Yeah, Dr. Ashok Mehta.
I'm from Mumbai. I'm a head and
Okay.
neck surgeon. I'm I'm 88 years. So
Okay.
you should imagine that before you were born, we were doing thyroid surgery. But anyway, the two things I would like to mention here. One is about the hypotensive anesthesia. You should keep your pressure around 100 or 85, 90. Then your bleeding will be very little. So I think that may be a point, especially for rural surgeons. You may not have hi-fi things, but at least you can have a bipolar cautery. If the bipolar cautery is used, probably you can do this entire operation without even ligating any vessel. So this is one of the things. Of course, energy instruments are much expensive, and maybe if you're accessible, then it's much better. As far as the recurrent laryngeal now is concerned, I think one should always use. I have been using for 35 years my my loops. So magnification will help you tremendously in preserving the recurrent laryngeal as well as the parathyroids. That vision becomes very clear and you're in a perfect place. I think they were very good job by all the speakers from the SGPGI. It's an academic institution of very high order. Congratulations to all of you for making superb presentations. Thank you very much.
Thank you, sir. Actually, you are joined at 6 sharp and it's 8:42. And thank you for blessing our young assistant professors. They have just finished their MCH and 2 months back, and they've joined as assistant professors here. And that this words of wisdom will take them long, actually. And thank you so much for again joining and even though it's a rural surgery thing, we try to now in rural India, we get, as you rightly pointed out, at least we should have a bipolar and a loop to do a good thyroidectomy.
These two things will help you. And hypotensive anesthesia, a
Yeah,
good
hypotensive
anesthetic.
anesthesia, if at all we have to.
A good extension of the neck. Sometimes you don't extend the neck properly, you have a difficulty.
Okay.
Simple things, but the simple things are overlooked.
Yeah.
Thank you, Dr. Ashok. Those were very kind words and wise ones. I just wanted to bring in one point. At the end of surgery, we can use a mild Valsalva to look for bleeders as well, along with the hypertension. That would help in any kind of post-op hematoma from formation.
You will be surprised. I've never injured a single recurrent in last 50 years. It's a
Oh, is it?
Yeah, this is where it is. People write all kinds of things, and we operate on large tumors, recurrent tumors, extensive tumors. It's because you're operating directly under vision.
Right. Thank you, sir.
Thank you very much. Bye-bye.
Thank you, Farin, and for that regarding Valsalva also. So last, anybody wants to say any comment or questions? Then we end this thing. Almost 3 hours.
Good evening, everybody.
Yes, Dr. Rajni.
I would like to congratulate all the panel members for conducting such a detailed discussion on safe thyroid surgery. And just on a lighter note, I would also like to highlight one more thing. A safe thyroid surgery could also include a ergonomically safe thyroid surgery for surgeons. That's all. Thank you. Thank you, everyone.
Okay, next time, when another 5-6 months later, when you become a faculty, we will ask you to speak on this topic especially.
Yes, sir.
Okay,
Sure, sir. Thank you, sir.
Okay. So if any more comments?
Hello. Hi, Dr. Sabha. I am Dr. Dipen from Gonda.
Hi, Dipen.
Yeah,
You have
I am
joined.
hearing all. I am listening all the lectures. It's all
Okay.
very good lectures. I revised all the thyroid surgery, and it's very interesting to learn new things and revise all these things. And simultaneously during lecture, we had a very seeing come across a patient with very huge goiter in Gonda, and
Okay.
we are supposed to do in 2 3 days, and just I am thinking about this all these device which we don't have at that time, like this vessel sealer and harmonic, and most of the time this bipolar and suture ligation and adequate hemostasis, good exposure, all these things will help. And particularly this thyroid surgery, one thing I must highlight, because this is in the forum of Rural Surgeon Association, because this Gonda is almost a tier 3 city, and we are performing about 4 5 major thyroid surgery in a month, and majority some patient were helped by that, and with adequate surgical anatomy and immunological anatomy knowledge and proper training, which we got all from SGPGI, very helpful to all of us. And I am just saying one word. We can perform thyroid surgery in rural India also with limited facility, and with because this is just like a open surgery with skill is more needed in that kind of surgery. Thank you, all the presenters. Thank you, Dr. Sava. I'm quietly seen all the lectures, and just saw the WhatsApp message, and I joined it. Thank you very much.
Thank you, Dipen. Dipender is my batchmate, actually. Me and Dipen did MCH together. Thank you,
Yeah,
Dipen. I also
yeah,
noticed that you joined and you were
yeah,
listening. And thank
yeah,
you so much for these words. Actually, he's one
yeah,
of the best
yeah.
thyroid surgeons, actually. And this one, and two alumni are there in Gonda. One Dr. Dipen and one Dr. Nikhil Singh also.
Yeah. Yeah,
Yeah.
Nikhil was there, and
So thank you so much again. And any other comments? Anybody? Akriti, Dr. Akriti ji, Mithilesh spoke, Akriti didn't speak. Dr. Meenakshi ji,
One thing I want to mention, sir.
yes, Madhu.
Robotic thyroid surgery has tremendous capacity to expand in near future, but in view of oncological safety and anatomical safety, we will not compromise these two safety in view for the just cosmetic satisfaction. So robotic thyroidectomy has a good capacity, and so for younger generation and for myself also, I will focus, and I would suggest everyone to focus on the robotic thyroidectomy for scarlet thyroid surgery. But at the same time, we have to remember the oncological safety and anatomical safety, which is paramount and which is utmost necessary for all of us. Thank you, sir.
Thank you, Madhu. Very important point indeed. Actually, that is very important. So, actually, so it's last thing is next series of lectures. We are going to have a contemporary surgical management of carcinoma breast by Professor Gaurav Agarwal, sir. He is the HOD at present at SGPGIMS and past president of Breast Surgery International. That will be a great talk, actually. People, please do join us for that talk also. Thank you. Thank you for have spent so much time with us today. Thank you.